different video. Today we're going to be talking about carpal tunnel syndrome, and it's going to be a short video, and we're going to be talking about all the important clinical aspects about it, as well as the anatomical structures that are involved. So let's continue. So the median nerve runs from the brachial plexus, goes down along the forearm, and it comes to innervate here your thumb, your index finger, your middle finger, and half of your ring finger, so the lateral half, or the half that's on the side of the thumb. Carpal tunnel syndrome is compression of the median nerve at the level of the carpal tunnel. The carpal tunnel is a tunnel which is actually running here within our wrist, and this tunnel is like a motorway tunnel which allows for vehicles to move through it. The vehicles that are moving through are nerves, blood supply, and flexor tendons. So here, the nerve that goes through the carpal tunnel is the median nerve and the flexor tendons. So once again, the carpal tunnel syndrome is compression of the median nerve at the location of the carpal tunnel over here. And at this level of the carpal tunnel, that's where the median nerve gets compressed, and that causes disturbances, tingling, numbness, and pain in your thumb, your index finger, your middle finger, and half of the ring finger. So just for an overview, that is where the issue lies, at the level of the carpal tunnel. The median nerve, here's another diagram which just shows the distribution of the median nerve. Again, it's these 1, 2, 3, 3.5 fingers. The ulnar nerve is always on the side of the pinky and the medial half of the ring finger. So when it comes to the anatomical structures involved in carpal tunnel syndrome, here is the carpal tunnel over here. The carpal tunnel runs through the wrist, and it's formed by these carpal bones, the carpal bones that you're all very familiar with, and then think about this. This is the palmar side. So the side of your palm is the side where there's this fibrous sheath or this fibrous band that runs along the roof of the carpal tunnel. And it's called the transverse carpal ligament, and it's very important. So this fibrous band on the palmar side of the hand forms the roof of the carpal tunnel, and it really ties together this carpal tunnel. And this entire structure here is where you get compression, and you get compression of the synovium, you get compression of this area of the flexor retinaculum. Now remember, the transverse carpal ligament and the flexor retinaculum are the same thing. They are the same thing. So you'll come across it in books, and you'll come across it on the web. The median nerve is over here. As you can see, it's a tunnel. This carpal tunnel is a tunnel, and it allows for the passageway of this median nerve, and that is exactly the basis of this syndrome. Here you have, again, this is the transverse carpal ligament. Remember I told you it's on the palmar side, and it forms the roof of this carpal tunnel, and obviously below this transverse carpal ligament is where this median nerve passes through, and as it passes through, it's going to innervate those fingers I've already mentioned, and it causes pain, numbness, and tingling. What else passes through the carpal tunnel? The other interesting things are these flexor tendons here. These other flexor tendons, they're all running through the carpal tunnel. What is carpal tunnel syndrome? Just to really hone it in there. Carpal tunnel syndrome is also known as median nerve compression, and it's a condition which causes numbness, tingling, or weakness in your hand. You can remember the causes of carpal tunnel syndrome. Remember, this is actually due to inflammation. So what might cause compression of the median nerve over here as it passes through? Well, there could be inflammation of the synovium, which is known as synovitis. Itis means inflammation, right? So you can have inflammation. You can get bulking of the structures within the carpal tunnel. You can get increased weight gain or obesity or edema of pregnancy, which can cause pressure on this carpal tunnel, because this is only a small tunnel which should allow for enough space for the median nerve to pass through easily and swiftly. As soon as this tunnel starts to compress, just imagine this tunnel shrinking and compressing, it's obviously going to impinge and compress on the median nerve, and as it does so, it will cause the problems that we've already discussed over here. Carpal tunnel syndrome can be due to REPOD, which is the mnemonic we're going to use here. R is for rheumatoid arthritis. E is for edema of pregnancy. E and P are for edema of pregnancy. O is for obesity, and D is for diabetes. So one more thing, here is the flexor retinaculum, or the transverse carpal ligament, and the reason why we keep calling it this transverse carpal ligament and why I'm reminding you of the name is because this is where the surgeon would cut in a escalated treatment plan. That is where you would do a longitudinal incision over here to cause release of the pressure of the transverse carpal ligament over here, and that allows for this median nerve to pass through more easily. Here's the compressed median nerve. Let's just be very clear. This is the transverse carpal ligament going across on the palmar side of the hand. This is the carpal tunnel, which is actually the space under this ligament. This is a ligament. This is where we would incise to actually release the pressure. Patient presentation in carpal tunnel syndrome. The patient is usually female in the 5th or 6th decade of her life. They complain of pain, burning, or tingling sensation in the fingers and the hand. Remember, which fingers were they? They're the thumb, the index finger, middle finger, and lateral side of the ring finger, or the side on the half of the ring finger, which is on the thumb side. The main causes would be synovitis. Now, remember, the tunnel may increase in bulk, and that bulk increase of the tunnel itself can cause compression of the median nerve, as in rheumatoid arthritis, which involves the synovium. Commonly, this is almost diagnostic for patients, is that the pain is worse at night. Because remember, carpal tunnel syndrome can also be caused by repetitive hand movement, and it's often caused bilaterally. So it's going to occur in both hands due to typing or some kind of like gaming or repetitive hand movement. Okay, so that means that it would typically occur bilaterally in both hands, and yeah, and the pain would be worse at night because most people are going to overuse their hands and hand movements during the day. So the pain is worse at night. There's two distinguishing factors for carpal tunnel syndrome, which we will remember right now, is that the pain is worse at night, and you may notice that the patient will notice that the pain may be relieved when they hang their hand over the edge of the bed. This is almost a diagnostic. This is a clincher for carpal tunnel syndrome. What are the 3 signs you must look out for as a clinician when it comes to carpal tunnel syndrome? The Tunnel sign, the Phelan's test, and thenar atrophy, which isn't really a sign, it's more so a complication. But I'll go through these one by one. The Tunnel sign. The Tunnel sign is when you percuss or tap on the carpal tunnel in this location, obviously. When you tap on the carpal tunnel and you do it, you're doing it, and as you do it, the patient would experience pain, numbness, and tingling in their 3.5 fingers, their thumb, index, middle, and half of their ring finger. And that would be the Tunnel sign. You could do it with an instrument, you could do it with your finger. The other way to do this is actually to trace up from the index finger, go all the way up, trace it all the way up to the elbow, but that's different. Phelan's test. Phelan's test is also known as the inverted prayer sign, as you can see over here. Inverted prayer sign. So you're taking your wrist, you're flexing them. So essentially, what are you doing? What the patient will be doing? Ask the patient to raise his elbows up, flex his wrist as much as he can in this inverted direction, upside down prayer sign. And as he's flexing, can you imagine that this part is at the maximal flexion over here and over here? And what is found there, ladies and gentlemen? Well, you find there the carpal tunnel. So the carpal tunnel would be there, and you can imagine how this would be increasing the compression. By flexing as much as you can at this level, you are increasing the already pre-existing compression on the median nerve. What is the patient likely to feel? The patient is likely to feel pain, numbness, and tingling over his 3.5 fingers, as we have mentioned. Yes, that is the Phelan's test. Thenar atrophy. Okay, let's talk about thenar atrophy. Okay. I'll come back to thenar atrophy, okay? But it is a complication Wasting of the thenar eminence is seen in late cases. I'll show you later. What investigation might you do for carpal tunnel syndrome? Electromyography and nerve conduction studies are very important. Treatment would initially be a wrist splint, something to kind of like keep the wrist in a neutral position, to keep it immobilized but in a neutral position, the wrist splint. Okay, and that, ask a patient to do behavioral changes by, instead of using their trackpad of their laptop, use a mouse. Wrist splint, NSAIDs. NSAIDs are your go-to drug here because you would have inflammation and excess edema, which is causing the compression on the median nerve. Treatment later on, definitive treatment would be decompression of the tunnel by incision along the flexor retinaculum. Typically, it's a longitudinal incision along the flexor retinaculum. And what does that do? Can you imagine if there's so much build-up pressure over here because of compression of the median, because of bulk increase, because of synovitis, because of RA, because of obesity, because of the edema of pregnancy? Remember, we discussed those earlier on. So if you relieve this here, if you make a cut here as a surgeon, that would relieve the pressure. Why is there wasting of the thenar eminence, and why is that a complication of carpal tunnel syndrome? Well, ladies and gentlemen, across the carpal tunnel syndrome, through the carpal tunnel syndrome, we have obviously something supplying this thenar eminence over here, and that is the recurrent branch of the median nerve. So the median nerve is going through here at the level of the carpal tunnel. After the carpal tunnel, it gives off a branch. The median nerve gives off a branch called the recurrent nerve, but it's kind of afterwards. It is after the carpal tunnel, and because it's after the carpal tunnel, that means that repeated compression over time would cause the damage to prolong and extend up to here, and that is what would cause your thenar atrophy. And take a good look at this normal thenar eminence over here, which has no folding, no creasing, no redness, and here there's a lot more creasing, redness, atrophy of the eminence itself. Finally, we're going to end off with one important question, one anatomical question. Why is the central palm base spared? Well, essentially, why are these fingers affected, but the palm itself here is not affected? And that is because the median nerve gives off a palmar branch, but it gives this palmar branch off before the level of the carpal tunnel, so somewhere over here. So it gives this palmar branch off before the level of the carpal tunnel. So that means the palmar branch passes superiorly to it to then go and innervate this area of the base of the center of the palm. And that is why it would be spared.